Okay, moving towards our next session, that is ARNI, Angiotensin receptor, is a new treatment for heart failure. To guide us regarding this, we have our next speaker with us, Dr. Arindam Pandey, a renowned interventional cardiologist. And to chair this particular session, I would like to invite Dr. Narayana Bhattacharya, another senior-most cardiologist practicing in Kolkata, and Dr. B.P. Pandey, the HOD cardiology in the National Specialty Hospital and also the founder member of HDS.
Hello, I think we are already late, so I will not take much more time because I think there is no need to introduce Dr. Arlndam Pandey. He is a prolific speaker and very energetic and versatile speaker also. And we will discuss a very interesting topic, that is ARNI, and that is, I think, that is the topic of the day actually. So we will start. Thank you.
Thank you, sir. Thank you for the moderator chairperson. Thank you, Howrah Diabetic Association, for inviting me to deliver this very important talk. But at the beginning, I would like to just rectify, ARNI is no longer a new therapy. ARNI is almost established, and this has become a standard of care. So I think the molecule now, we can call it a little old therapy, but very interestingly, it is surprising us every day with newer avenues, newer indication. And that is the thing which I'll try to focus today. So ARNI optimizing heart failure treatment across the continuum. So why this topic? Because at one point of time, the ARNI initial trial, which actually took ARNI into forefront, paradigm heart failure trial, you all know about it, were done in stabilized heart failure patients. So mostly the patients who were seen in OPD basis, they were included in the trials. And that is why the recommendation also came in that favor. But we know in heart failure, if you just neglect hospitalization, that is not done, because hospitalization in heart failure is very important, extremely important, and all the data, all the trials have clearly shown the number of hospitalization is directly correlated with the mortality of the patient. So this has something to do with the survival of the patient. Now there have been good number of data. This is one of them, has shown that if you can actually reduce the hospitalization, then the probable future of the patient is better. Now, higher mortality within the first month of discharge, this is another very important aspect which many a time we neglect, because the landmark trial, all the patients were OPD patients, so any patient who is hospitalized, they are not supposed to initiate ARNI, and if we see, not only during the hospitalization mortality is high, immediate post-hospitalization 1 month probably is very, very important. Very, very important, because in this period you can have a recurrent hospitalization, or you can also have a chance of mortality. So only it is possible if you start the lifestyle modifying therapy in hospital, otherwise you are going to miss the initial 1 month. And generally in my practice, I call the patient of heart failure ACS after 2 weeks. So initial 2 weeks probably is more important than the second half of the 2 weeks, second half of the month. So if you do not start the lifestyle modification and other lifestyle changes and important therapy which has shown to improve the mortality, then you are going to miss the initial 2 weeks to 1 month period, which is actually very, very vital. So that is why later on, all the important therapy for heart failure, they were evaluated in hospitalized patient, in acute decompensated heart failure patient. Now, if we see someone who is getting admitted, there are few key steps in the management of hospitalized patient of heart failure, particularly talking about heart failure with reduced ejection fraction. Early phase of intensive management, where the patient actually hemodynamically is very unstable, they might need inotropic support, they might need intravenous diuretic, and also some other form of medicine in the form of antibiotic and all. Then there is the intermediate phase of stabilization, or we call it transition from the intravenous to the oral medication, and the late phase of discharge and outpatient management. Now, if we see the natural trajectory of heart failure patients who are actually getting hospitalized, you can see at this point, if my cursor is the trajectory can be on the three sides. Patient may actually get further deteriorated, some of them will die, some of the patients will remain same. They are not improving, the heart failure status is not improving, whatever you are doing, and they become somehow dependent on the support system, inotropic and all, and majority of the patients, they actually start improving. So this is the actually ideal time when you should think about optimizing the therapy. So once diagnosed, GGMT is very important and it further aids in deterioration of the clinical status. Now why I am saying so? Because if we see the data, Indian data, we do have good amount of data from South India, Kerala Heart Failure Registry, we have data from Trivandrum Heart Failure Registry, where we found that our patients, they actually die more commonly compared to the rest of the world. In fact, the 5-year mortality in heart failure with reduced ejection fraction is 50% in the Western literature, but in our country it is actually 3-year mortality. 3-year mortality is 50%. So why our patients are dying higher number? So probably there are important issues. One of the very important issues is the inertia, both from the physician's point of view as well as patient's point of view. Many times medicines are prescribed, but patients feel good after discharge, they do not take the medicine. And sometimes due to physician's inertia, all the important medicines which are shown to alter the mortality of the patient are actually not prescribed in proper fashion. So both are important, and in the prescription audit it was found that the 4 foundational therapy of heart failure actually were not prescribed adequately in the Trivandrum Heart Failure Registry. So that is very important. Now early treatment initiation in hospital is associated with the improvement of the adherence. So, multiple trials have shown if we can start the medicine during hospitalization, because patients are in pain, they have shortness of breath, they know the pain of getting hospitalized. If we start something there, the chances of compliance is far better. Now, there are important reasons for deviation of the guideline related therapy. All the time it is not inertia, there might be other issues, say for example, renal dysfunction, hypotension, low albumin, plan for outpatient, diabetic, etc., kidney deterioration. But if we see as a whole, 2021 ESC guideline, they recommend, it is recommended that evidence-based oral medication treatment to be administered before discharge. There have been good amount of evidence. Strong heart failure is very important trial which has clearly shown that if we actually prescribe the molecule in hospital, the survival benefit is definitely there. So based on that, now it is recommendation as well. 2021 ESC has cleared out the doubt that whatever therapy has shown to improve the survival, they are supposed to prescribe in hospital. And it is also said, this is the ACC 2022 guidelines, they say inpatient or patient of in-hospital patient of heart failure with reduced ejection fraction, GDMT should be initiated during hospitalization and after clinical stabilization is achieved. So almost uniform guideline from both the important bodies. So what is the preferred choice of RAS inhibition in hospital patient of heart failure with reduced ejection fraction? If you see the available evidence, ACE inhibitor ARNI, unfortunately they do not have any evidence in hospitalized patient. Mineralocorticoid receptor, they have limited evidence from observational single center study around 685 patients who were discharged after admission, and it was shown in that trial that delayed initiation of mineralocorticoid therapy, that is 30 to 90 days post-discharge, was associated with significant increase of mortality. So small evidence but strong evidence, clear evidence, that is their beta blocker, one open label trial, impact heart failure, again a small trial incorporating 363 patients, showed a trend towards benefit from in-hospital initiation of carvedilol versus initiation of any beta blocker after 2 weeks of discharge. So that any amount of evidence we do have. But the problem is, if you see the in-hospital trial, there are actually now good number of trials. Soloist trial, we all know about Soloist trial. This was done with SGLT2 inhibitor, both SGLT1 and SGLT2 inhibitor. And very interestingly, this trial, Dr. Deepak Lal Bhatt was the chief investigator. Both heart failure with reduced as well as preserved ejection fraction were included. But as we see the heart failure trials of the SGLT2 inhibitor, contrary to those, this particular trial, they were done only in diabetics. So 100% patients were diabetic. So as of now, combined SGLT1 and SGLT2 inhibition is not recommended for non-diabetic individual. But very interestingly, in soloist heart failure trial, in-hospital treatment initiation was 49%. So around 50% patients were initiated in hospital. So that is a very strong data, and the data result all of us know. Galactic heart failure has been withdrawn because of some important issue. I'm not going to detail. That is some myosin chain activator, but that had some issue. That had elevation of troponin I in this trials arm. So it was as of now withdrawn. Victoria trial, we all know, Vericiguat is an important medicine, particularly something called worsening heart failure. Worsening heart failure is a situation very similar to heart failure hospitalization or acute decompensated heart failure. And in this trial, around 11% patients were initiated in hospital. Now, Pioneer heart failure and Impulse trial, they were small trials, but 100% patients were in hospital. So Pioneer, we all know this was a feasibility trial of ARNI, which was done in hospital, acute decompensated patient, and Impulse trial was done with empagliflozin. Again, 100% patients were actually in hospital. Both were actually, evaluated in both non-diabetic and diabetic individuals. So that is very important. ESA 21 guideline clearly say that initiation of ARNI in recently hospitalized stable patient with reduced ejection fraction, including those who were on ACE inhibitor or without ACE inhibitor. That means the named patient. It is a class 1 indication. Similarly, 2022 ACC guideline clearly says that clinical evidence backing sacubitril valsartan. I already mentioned about the Pioneer heart failure trial. Another trial known as transition trial, which I did not mention here, was also done in hospitalized patients. That was actually a feasibility trial, and whether the maximum possible dose of ARNI were achieved with in-hospital initiation of ARNI or compared to conventional initiation. That was one of the endpoint, and it was found that it is possible that if you reach the higher dose of ARNI, which has shown to improve the survival better with in-hospital initiation of ARNI. And similarly, Pioneer heart failure trial showed that because this Pioneer heart failure, they also evaluated the patients of NT-proBNP. So there was significant reduction of NT-proBNP with in-hospital initiation. So both the trials are actually sufficient to say that ARNI is actually should be started in hospital irrespective of the status. So I'm not going to detail Impulse study, though my talk is on ARNI, but this was one of the latest trial with empagliflozin, more than 500 patients, 10 mg empagliflozin versus placebo. We can see the inclusion criteria. So that is very important. Which patient, at what point we are supposed to start either SGLT2 inhibitor or ARNI. So this trial is very nicely structured. So I thought I should show the inclusion criteria. So currently hospitalized for primary diagnosis of acute heart failure, who meets the stabilization criteria, randomization done after more than equal to 24 hours, no later than 5 days. So after 1 day, but within 5 days of admission, as well as possible after stabilization and while still in the hospital. So elevated NT-proBNP, BNP was the inclusion criteria mandatory. Treatment with minimum dose of 40 mg of IV furosemide or equivalent over IV loop diuretic. And what were the exclusion criteria? All the patients are cardiogenic shock. So secondary cause of heart failure trigger, planned or previous cardiovascular revascularization, recent ACS, MI, stroke, TIA, eGFR less than 20. So you can see in this trial, empagliflozin, the cutoff of eGFR was 20, and all type 1 patients they obviously were excluded. So this inclusion and exclusion criteria is very important. You should keep in mind whenever we are trying to initiate SGLT2 inhibitor in hospital, and actually they are very similar to criteria which are required to start ARNI in hospital patient. And the study result was fantastic. And so the following criteria, 1, 2, 3, 4 criteria, of every time we should keep them in mind whenever we are starting ARNI or SGLT2 inhibitor in hospital. Systolic blood pressure more than equal to 100 and no symptoms of hypertension in preceding 6 hours. Though the ARNI trial it was preceding 24 hours, but empagliflozin went one step forward. No increase in the IV diuretic dose for last 6 hours. No IV vasodilator including nitrate within the 6 hour randomization. No IV inotropic drug within last 24 hours. Those are the mandatory requirements before you can actually start this lifestyle modifying therapy in hospital. And you can see the trial result, I am not going to detail of that. So how you are supposed to start, which molecule first, whether it is ARNI, whether it is SGLT2 inhibitor, beta blocker. Now there are two ways of starting. One is rapid sequencing, which is actually Dr. McMurray and all other pioneers of heart failure research. They actually propose this rapid sequencing, and we all know about it. So beta blocker SGLT2 inhibitor in the step 1, followed by ARNI in the step 2, and step 3 is the glucocorticoid receptor antagonist. And another way of starting is actually all four together. All four together, if the patient, if you feel use your clinical acumen. So if the patient can actually tolerate, you actually can start all of them together. That is also okay, and that is also supported by the guidelines. So these are all four important therapy which has shown to improve the mortality. Regarding the dosing recommendation of ARNI, it is important because initiation and uptitration of sacubitril valsartan, there are some rules to be followed, particularly if you are replacing ACE inhibitor. If you are replacing ACE inhibitor, if the patient is on less than 10 mg dose of enalapril, you are supposed to start at a dose of 50 mg twice a day. Obviously, to give a washout time of 36 hours, followed by 50 mg twice a day. If the patient is on more than 10 mg of enalapril, 100 mg twice, you can actually start after 36 hours. Then you should actually try to increase the dose, because higher the dose, better is the benefit. Now in CKD patient, if the eGFR is not normal, up to eGFR of 60 actually up to 60 to 30, there is no dose adjustment recommended for ARNI. But if the eGFR is less than 30, you are supposed to start at a lower dose to a 50 mg twice a day, gradually increasing the dose. Maximum dose, obviously, even in low eGFR, is actually 200 mg twice a day. There have been trials of ARNI in hemodialyzed patient as well. Hemodialysis patient is off-label indication, you can still start it. You should start at a lower dose, 50 mg twice a day, and maximum dose recommended is 100 mg. So that is how you are supposed to do. So simultaneous uptitration of GDMT. So you should actually, along with ARNI, you should try to start other therapy. All are important, and together you can actually update it together, all of them. Now there has been good amount of evidence which has shown that hospitalized patients, if they are initiated with ARNI, is a robust reduction of outcome. So they are now standard of care. So if I just sum it up, initiate GDMT like sacubitril valsartan early to manage heart failure with reduced ejection fraction patient. It is backed by the guideline, important guideline, ESC, ACC. Timing of initiation therapy is essential. I have already mentioned regarding the ideal timing of initiation, reduce the risk of mortality and further heart failure hospitalization, which again is important for subsequent survival of the patient. At the same time, it also improves the quality of life and symptom of the patient as well. Thank you very much.
Thank you, Arindam. Is there any question from the floor? Use the mic.
As far as the usage of MRI is concerned, how you place epinephrine as a therapy for heart failure? What is the present scenario?
So as of now, epinephrine and spironolactone, they are in the same position. But if you look into the data, evidence, you find more data on epinephrine in post-MI heart failure patients. Whereas if you don't take MI or ischemic heart disease as an etiology, is evidence with spironolactone. So in my practice, I have found that spironolactone probably is a superior molecule compared to epinephrine in terms of heart failure outcomes and symptomatic improvement of the patient as well. But then they have a very important side effect of painful gynecomastia, which is quite common. In my male patient, my female patient, I don't have any problem, but in male patient it is quite common. So it is not uncommon that I need to change them with epinephrine. So non-ischemic, non-post-MI, automatic choice is definitely spironolactone. In post-MI, I do give preference to epinephrine, particularly male patients.
What about finerenone? What is the
Finerenone, as of now, we do not have any evidence in heart failure. Whatever evidence we are having are in diabetic kidney disease, either in terms of reduction of proteinuria or in terms of retardation of the proliferation of the CKD. In those patients, it was clearly shown that if we initiate them for this indication, they reduce the heart failure chances. So mind you, they reduce the heart failure possibility in this diabetic or heart failure. So, it is
So in fact, heart failure reduced EF was an exclusion criteria for Finzeradone. You can use it for a primary preventive therapy in diabetic DKD patients. So that's the current status. But probably it has a great role in heart failure preserving. So I think we are running late. I would like to thank Arindam for a beautiful presentation. So it's our pleasant duty to felicitate. Please come forward.
Now it's time to felicitate our another chairperson, Dr. Arlndam Pandey, sir.